Could high cholesterol and even LDL cholesterol actually be better if we're concerned about longevity and all-cause mortality? Now, this statement might surprise a lot of you because the general consensus is that LDL is bad, high cholesterol is bad, and a lot of clinical guidelines are shaped around that narrative, and a lot of doctors are treating around that narrative as well. And although there is research that does show some improvements in people with ischemic heart disease and previous myocardial infarctions with lipid-lowering medication, it doesn't give us the full picture. And for those of us who are healthy and care about longevity, or even in those who do have underlying cardiovascular disease, but also care about all-cause mortality, which is dying from any other thing, the picture is a little bit different and there's a lot more nuance. And in fact, there's a growing body of literature over many decades now showing that those who have higher levels of cholesterol, including higher levels of LDL, actually have a lower risk of all-cause mortality. And one of the issues that a lot of people end up seeing when they make healthy changes to their lifestyle or make changes to their diet, particularly if they go keto or they're going generally low carb, what can often happen is people end up getting overall improvements in every aspect of their health, both functional markers and biomarkers, except for one thing. Sometimes their LDL goes up. And this is where this conversation gets a little bit more important, because if all markers are improving except this one LDL, then we have to stop and ask the question of, is this one marker that's slightly elevated really that important? And do you need to go on medications to lower it? And what are the effects of lowering it? And so recently I wrote a whole article looking at this aspect of research around the cholesterol mortality paradox, whereby those who have higher levels of cholesterol and LDL tend to have lower risks of all-cause mortality. And so I'm going to jump into that here, but if you want a lot of the details and a lot of the actual nuance around the papers, then I recommend go read the article either on my website or on my Substack. But I'm going to cover it in broad details here. And of course, before I get started, none of this is medical advice. This is purely just for educational purposes only. If you're going to make any changes to your medication or lifestyle, always speak to your doctor or specialist. And please remember to support the channel by liking and subscribing, as that's really going to help me out and it's going to help me grow and get more information out to you guys. All right, let's dive into this video. So although cardiovascular disease is still the #1 killer and ischemic heart disease plays a major role in that, we still want to consider the larger picture of all-cause mortality and dying of other things. That doesn't take away the importance of cardiovascular disease and ischemic heart disease. We still need to consider that as well. But we need to look at the broader context when we're making a risk-benefit ratio sort of determination for our own personal health. And that's a major consideration when we're thinking about ways to optimize our health, and we're not looking at things from a public health perspective. You know, what applies to the many may not apply to you as an individual, particularly if you have generally good metabolic health and you're overall very healthy. And the first study that I looked at in this article by Sang-Wook Yi et al. In 2019 even states the importance of considering all-cause mortality versus just cardiovascular disease. And they even state, although disease-specific morbidity and mortality, such as ischemic heart disease mortality, have their analytical merits, all-cause mortality is arguably the most important endpoint for patients or the general population when assessing risk factors and the effectiveness of a treatment or public health intervention for life-threatening diseases. So that kind of pulls it out right away that we need to stop having our blinders on and focusing purely on ischemic heart disease and atherosclerotic cardiovascular disease, and we need to consider the wider lens when we're looking at treatment paradigms that are quite blanketed across the population, such as statins. Now, this is the first paper that I looked at. This was done in a very large population. They had about 12.8 million participants. This was done in Korea, so keep that in mind when we're considering where these people are from. But what this study showed aligns with what a lot of the other research is showing within this cholesterol and mortality space, which is a reverse J-curve, which means that basically on the low end of cholesterol, we have the highest rates of all-cause mortality. That lowers as we move towards the mid-range, and then as we go again up into the upper range, it starts to come up again. However, being a reverse J, the highest levels which we can see in these charts here are in the lower ranges, and that was across the board. And we can see as we move towards the higher ranges, there's less of an increase within these hazard ratios. So the highest risk is at the lower ends. What this paper found as the lowest risk was around 200 to 240 milligrams per deciliter, or around 5.2 to 6.2 millimoles, depending on what units you're using. So this already goes off of the paradigm of lower is better, right? A lot of people within the ranges pushing into 6, a lot of doctors would be concerned about when looking at total cholesterol. But within this paper, this is where they found the lowest risk of all-cause mortality. And the study did account for many things. Again, you can go into the details in the article where they look at the different types of confounding variables they looked at. What was nice with this study is they did pull out for each age group and also the different brackets of cholesterol levels that they actually had. And you might be saying, most doctors nowadays aren't really that focused on total cholesterol, and I would agree. Hopefully the good ones at least aren't, and even LDL they're not too specific about. But they often look at the bigger picture and consider HDL in there as well. And so the next paper we looked at that was published in The Lancet in 2007 actually accounted for the different types of cholesterol molecules. So they actually accounted for HDL and also total to HDL cholesterol. And they looked at both IHD, ischemic heart disease, and stroke as some of the major outcomes, and then also all-cause mortality. But for what we would assume is supposed to be important in relation to ischemic heart disease and total cholesterol, this paper actually showed that when we look at HDL, the higher the HDL, the lower the risk, even in the higher levels of LDL. So when we account for HDL, it attenuates the response to elevated LDL. And when you look at the total to HDL cholesterol, the lowest ratios had the lowest risk. So again, it takes away the picture of just, high cholesterol bad. We need to consider the nuance of, what is the actual ratio between LDL, HDL? And then we can always go deeper into things like ApoB as well. The other good thing about this study is they did look at various confounding variables, and what they also found was that the association with ischemic heart disease with the higher total cholesterol was pretty much completely attenuated when they accounted for age and blood pressure. So again, the total cholesterol is not necessarily causative in the role. It plays a part, but when we account for overall good health, low blood pressure, that response seems to not be there, which would suggest that the cholesterol in and of itself being high is not necessarily problematic for a healthy individual. So what if we look at actual LDL, because that is the so-called bad cholesterol, and this is the one that everyone is talking about. So the first paper I looked at was by Yao Lui et al. In 2021, which is titled The Association Between Low-Density Lipoprotein Cholesterol and All-Cause Mortality, Results from the NHANES 1999-2014. So as this paper suggests, they use the NHANES population, which is a very large database and well recorded. They had about over 19,000 participants that were within the criteria that were followed up over just about 8 years. So pretty good sample size, pretty good duration in time. And what this paper also found in the age-adjusted model was the lowest LDL had the highest risk of all-cause mortality. And we can see this painted very clearly in their hazard ratio plots. Here we can see that the lowest LDL under 70 has the highest odds ratio. And again, we see this somewhat inverse J curve where it drops down as we go up a little bit and then a slight bump up. But what we can see is even in the individuals at over 160 milligrams per deciliter, the hazard ratio is virtually 1. So there's no increased risk in these populations in various different models, whether they accounted for age or they accounted for other diseases. And so yet again, we see that this doesn't line up with the lower is better when we're talking about all-cause mortality. We can see in this spline chart as well the very clear inverse or reverse J-curve association. And what's notable here is in the lower ranges, we have significantly higher rates. And as we move into the higher ranges, it kind of flatlines a little bit. It goes up slightly, and we can see the confidence intervals are much larger as you go higher. But the thing to keep in mind with this over time is as you go up, there are often other confounding variables and other diseases which might be at play. And it tends to also be in older individuals that the LDL can be higher. So there's a few confounding variables, and although they account for it, they still might come off here. But it's quite noticeable that the increase as you go higher, and keep in mind, this is LDL. So an LDL over 240 is significant. It's not much higher than a hazard ratio of 1. Interestingly, in this study as well, what they found is that the lowest LDL actually had the highest risk of cardiovascular mortality, which completely goes in the face of the narrative of getting it as low as possible. And they found that the fourth highest had the lowest incident. So that was between 130 to 160 milligrams per deciliter, or about 3.3 to 4 millimole. Again, when you look at the guidelines, this is significantly higher than what they would typically want to see, even on a standard panel for a healthy individual. But focusing mostly just on all-cause mortality, we've got a couple more papers to look at here. So the next one looked at in this article was a paper in 2020 by Ditlev et al., titled Association Between LDL and All-Cause and Cause-Specific Mortality in Denmark, Prospective Cohort. So this was obviously a group from Denmark. They had over 100,000 participants that were followed for about 9 years. So again, good duration, long enough to see some change in cardiovascular risk and a good sample size. And they too found the same thing. They found a U-shaped curve with all-cause mortality, whereby the lowest and the highest seem to have the highest mortality rates, with the lowest centiles having the highest rates of all-cause mortality. And in this study, they reported that the lowest risk was actually at 3.6 millimole for LDL cholesterol. Again, quite higher than what the clinical guidelines typically outline. But like the previous paper, what we can see is when we look at the hazard ratios plotted, we can see even in the upper ranges of 4 to 4.8, it's still hovering around that 1 hazard ratio, meaning no increased risk. And it's only until we get into the over the 4.8 that we start to see an increased risk. So in general, the higher levels seem to be much more significant in relation to its protective effect against all-cause mortality. And in this paper, like one of the previous ones I mentioned, what was interesting is those in the highest centiles, so in the 81st to 95th and in the 96th to 100th, they actually had the highest levels of pack years for smoking and also had some of the highest blood pressure, both of which are risk factors for cardiovascular disease. So it's interesting that we see a lower risk at a lot of these levels. Of course, statistical analysis accounts for those variables, but you can only account for so much. Usually some of that would still come across, but interesting, needless to say. And we see the same sort of results in the next paper we looked at by Sung et al. 2019, where they had the same findings. So a higher risk of all-cause mortality was observed in the lowest LDL group compared with an LDL of 100 to 129 as the reference group. And this remained after accounting for confounding variables. So again, they accounted for other diseases, age, etc. What was nice with this model is they actually accounted for HDL, again, like we talked about. So if they account for HDL, what this study found is actually the higher levels of LDL between 130 to 160 or so, and even up to 160. In model 3, where they accounted for HDL, they saw the lowest hazard ratios. So here again, we see higher LDL along with a higher HDL has the most protective effect against all-cause mortality. And like the previous study, this was also in the face of the highest groups being 130 to 160 and over 160 had the highest levels of a lot of poor metabolic health. So they had higher triglycerides, they were the highest smokers, and they also were in the diabetic or pre-diabetic range compared to other groups, and also had hypertension. So it's interesting that it seems in the face of all of these risk factors for cardiovascular disease and risk factors for disease overall, those that had the highest LDL had the lowest rates of dying from all causes. So these are not the only studies around, but this sort of aligns with a lot of the growing body of data that shows this cholesterol mortality paradox. And they also show very similar effects. And I think these studies were done quite well. They were quite high powered, large cohorts, statistically done very well and followed over longer periods. So we can infer from this that it's very clear that a moderately higher total cholesterol and even LDL is protective against all-cause mortality. So we need to consider that. A lot of these studies, as I said, did account for various confounders, whether other diseases. Some accounted for lipid-lowering medications, some did not. And a lot of them also accounted for reverse causality by removing people who died early in the studies. Some included people with cancer, some not. And that ties into the frailty component as well, because the argument that a lot of people make, which I outline in this article here, is that they confound low LDL with some markers of frailty or cachexia, say, associated with cancer. The fact that many of these studies accounted for cancer by either adjusting for that confounding variable or removing people with cancer removes that as a potential argument, because the data still applies even in those without cancer. However, frailty may still be a role. And so I looked at a paper that wanted to answer this question: is frailty itself the reason why those with low LDL have higher all-cause mortality? And what this paper found was no. When they accounted for markers of frailty, of which they had many, both functional markers and biomarkers, the association between the lowest levels of LDL and the highest all-cause mortality was still present. So frailty is not the reason why we see an increased all-cause mortality. Now, the other potential thing to mention here that could be a player is something called selective mortality. And that's where the individuals who tend to live longer may have some genetic protection against, say, cardiovascular disease or something of that nature, whereby those with those genes will live into older ages and then just naturally will be able to live with higher LDL and not have death or disease. Those who do not have that conferred benefit of genes will likely die younger, and that could be why we see some of this data, although it seems unlikely given the range of data that we have across the age groups and the amount of things that they've confounded for and accounted for. And we see this in many different ethnicities. So whether we're looking at Caucasian, Asian, we see it across the board, and a very wide age group. So unlikely, but it's still something to consider, that maybe people have some sort of genetic protection which prevents them from having cardiovascular disease with an elevated LDL, which is why they live longer and thus have better mortality rates. So in general, to bring it all together, answering that initial question of is lower better, is cholesterol in and of itself bad, is high cholesterol, even LDL, potentially bad? And I would say based on the data that we have here, the answer would be no. However, there's of course some nuance and some context there. So this data clearly shows that a higher total cholesterol in the range of about 5.2 to 5.6 millimole per liter is protective against all-cause mortality, and an LDL between 3 to 4 millimole per liter is protective against all-cause mortality, which is significantly higher than what a lot of the clinical guidelines like to see for ischemic heart disease or cardiovascular disease. And this is likely because the whole area within cholesterol and LDL is probably missing the true cause of cardiovascular disease, being underlying poor metabolic health, inflammation, and damage to the blood vessels. So this is the whole notion of, yes, LDL is necessary but not sufficient, meaning LDL in and of itself can't cause atherosclerotic cardiovascular disease, but it is necessary in the etiology of it. And as I said, the main things there are going to be more metabolic dysfunction, inflammation, vascular damage, etc. So in the context of someone who maybe has poor metabolic markers, it may still be important to consider lowering your total cholesterol or LDL. And of course, you'd have to work with your doctor and specialist on that. However, you need to consider the aspects of your potential reduced protection against all-cause mortality, whether that's for cancer, viral infections, or other things. So it's not necessarily lower is better, but maybe bringing you into the second or third centile ranges opposed to the lowest. So this is an important conversation to have with your doctor if you are within that demographic. Now, things that I haven't discussed here that I've mentioned a little bit are, what are those other markers that are more important? And so for me personally, I think there's a large subset of data now that shows more significant risk markers for cardiovascular disease. And that's going to be things like lipoprotein little a, ApoB, maybe a bit. There seems to certainly be some correlation there, but there's again some context. Things like homocysteine, metabolic markers, so HbA1c, fasting insulin, fasting glucose, even doing oral glucose tolerance testing. Those things are going to be really important. Inflammatory markers, fibrinogen, the glycocalyx markers, homocysteine. There are a lot more biomarkers that we can look at that are probably more specific to your potential risk of cardiovascular disease than just looking at total cholesterol and LDL. And of course, if you are concerned, there are non-invasive and invasive measures and investigations to use, things like calcium scan, coronary calcium scan. You can do the coronary CT angiogram, which is going to be the gold standard for looking at plaques, both soft and calcified plaques around the heart. You can do things like a coronary intima media thickness scan, or CIMT, which measures the arteries going up in the neck for any signs of plaque. You can do things like an ankle brachial index, ABI, to measure things like how healthy your blood vessels are, or even doing something like a flow velocity analysis, which is probably more specific to how healthy your blood vessels are and what the flow is actually like within them. So that gives you, a much broader and more nuanced view within this cholesterol longevity space, and also within some of the biomarkers and investigations that you can use. So if it's something that you're concerned about, obviously talk with your doctor and weigh up the pros and cons, because the main thing here is every individual is different, and you want to make sure that what you're doing for yourself is personalized and applies to you and your particular health and health journey. All right, if you like that content, make sure to like and subscribe, and please leave a comment. This is a very nuanced topic, and I'm sure there are a lot of people with different opinions. I'm just a simple clinician looking at some of the research, so I'd love to start some conversations going around what you think about this, and maybe if you have research that shows the opposite side, then please by all means share it, and let's start a conversation. And I'll link to my article and all of the things I've talked about here, and I'll also link to a couple people I recommend looking into who are specialists in this space, whether cardiologists or lipidologists. All right, see you guys in the next video.